So these are the approved CDK4/6 inhibitors, all of which, interestingly enough, I think a lot of their behavior can probably be predicted by their IC50s. I think that palbociclib and ribociclib are equipotent, and it's really the potency as opposed to their kind of ratio to the CDK6, which is responsible for the neutropenia. And it's interesting though, palbociclib is about the same, 11 versus 15, where ribo is 10 versus 40. And although interestingly enough, the amount of neutropenia is about the same with both of them. And abemaciclib has a higher, or I guess lower IC50, so it's more potent. And it's a 5-to-1 ratio between CDK4 to 6, so there's less neutropenia with this drug. And as you can see here, palbociclib and ribociclib are given 3 weeks on, 1 week off to prevent the neutropenia. But because there's a 5-to-1 ratio with abemaciclib, in terms of the CDK4/6 ratio, you can give it continuously, which is what we do with abema. And there are all these very large clinical trials that have been for all of them. Palbociclib was approved over 5 years ago, and abema was the last one that was approved actually in 2017. So here's the data from the first-line metastatic trials, and really looking overall, there looks like there's a little bit more response rate with palbo than maybe with ribo, but I wouldn't put too much stock in that. I think that generally they're all better than the control arm. That's the most important thing, and clinical benefit is better than the control arm, and there's a near doubling of progression-free survival regardless of which agent you use. I think that's a really important thing because we all get a lot of kind of, detailing or whatever by the various pharmaceutical companies, pointing this one and that one. And while there may be some subtle differences, in particular with abemaciclib, because you can give it in later lines of therapy, but really I think, at least to a first approximation, except for toxicity, I think they're all pretty much the same. Second-line trials are shown here. I think that, again, we get about a doubling of progression-free survival. There are survival benefits, at least with ribociclib and abemaciclib, that look to be statistically significant, that are substantial. I think the big difference, though, with the palbociclib trial is the patient population. And it's really important to note that a lot of people had chemotherapy on PALOMA-3, probably, at least as you can see here, about 45–50% of the patients. So that's why. I mean, I think people who have been pre-treated already with chemotherapy, might not necessarily have a survival benefit potentially to CDK4, but I think it's pretty close. And these trials, I think, really weren't designed for those endpoints anyway. So this just looks at the survival of abemaciclib and fulvestrant, showing what we said before. This is second-line therapy. There's a 9.4-month overall survival benefit, which is really substantial. I think the big thing you can tell women, is that, look, you're almost to 4 years of overall survival now from a disease that, you read on the internet, would be a lot less. And so I think this is a really good thing in advancing the field in this way. And this is actually second-line therapy. This is even first. This is 48 months after progression, probably after a year of your initial endocrine therapy. So you're really talking now 5 years, not necessarily 4. Mona Lisa 3 does the same thing. There's a relative risk of death that was reduced by about 28%. And, again, I mean, the median survival has not been reached in this trial. It's really gratifying to see, that you're out like almost 4 years and over 50% of the patients are still alive, which I think is really gratifying. So again, the big difference between all these agents is really how they're given, and not how they're given, but what the toxicities are, and and actually how they're given too. I mean, abema and palbociclib, they come in dosage forms, where you really have to kind of, if you want to dose reduce somebody, you have to potentially get another prescription. Where ribociclib is a 200 milligram tablet, they can just alternate the tablet strength. And the major toxicities you can see here: neutropenia and thrombocytopenia to a lesser extent, and fatigue really is with abema. But on the other hand, you have to watch diarrhea with abema. You have to watch increased QTC interval with ribo. Although I think in these days, in this day and age that we're in right now, QTC has become suddenly very important with some of the drugs that are circulating. But nonetheless, it's something that needs to be watched. And again, pabo is the same thing. There's rare diarrhea, anorexia, and fatigue.